You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Shawn McNeil, and today we'll be joined by Dr. Simeon Kimmel. Dr. Kimmel is an assistant professor of medicine at Boston University School of Medicine and an attending physician in the sections of general internal medicine and infectious diseases at Boston Medical Center. He's an author with a piece in the Journal of Addiction Medicine entitled Rejection of Patients with Opioid Use Disorder Referred for Post-acute Medical Care Before and After Anti-discrimination Settlement in Massachusetts. So Dr. Kimmel, thank you for joining us on the podcast. We're very glad to have you here. And I would like to start, as we usually do, by having you introduce yourself and speak a bit about how you got involved with the study and treatment of addiction.
I first became interested in addiction medicine, seeing patients with injection drug-related infections in the hospital as a medical student and as a resident. And at the time that I was in training, there was the standard of care really didn't include offering medications for opioid use disorder in the hospital. It was just starting to change, and so it was this moment where the lack of access to evidence-based addiction treatment really inspired me. And as a result of those experiences, I went on and did a joint infectious disease and addiction medicine fellowship at Boston Medical Center, and that's kind of how I came to this set of topics.
Fantastic. And just so that we can gain some perspective, prior to the settlement between, I believe it was the state of Massachusetts and the Charlwell House, how widespread was this issue of these patients and their post-acute care referrals being rejected due to the fact that they were on opioid agonist treatment?
So I think it was extremely widespread, and that's really what led us to look at this. You know, talking to the case managers, there were a few select nursing facilities that they knew of where they would specifically refer people to, but by and large, facilities across the state were declining patients. And I think if you were to talk to inpatient hospitalists or infectious disease doctors or other people taking care of people with addiction who pass through the acute care hospital, everybody knows this is an issue. And fortunately, there's an ally in the U.S. Attorney's Office who really took an interest in this issue and is trying to hold these facilities accountable.
I think that's a positive change. You mentioned that your study looked for referrals that were rejected due to a mention of the patient's substance use or the fact that they were on opioid agonist treatment. However, this does not account for referral rejections that did not include a comment. So do you feel that this results in an underestimation of the discrimination, and by how much do you think it was underestimated?
Yeah, so our initial goal was to do a study that compared facility acceptances for people with and without opioid use disorder. And as we started to look at what was happening in our facility and look at the data that was available, we realized that there was this electronic referral system, which is really a novel source of information. And the electronic referral system had these comments that were transmitted back from facilities. And not all facilities transmitted back comments. But when we were looking through these comments, we saw that there were all of these facilities that were stating, not taking this patient because of methadone. We don't take people on Suboxone. And we thought that this was really something that needed to be described. So I think that this paper demonstrates that there's explicit discrimination against people with opioid use disorder who are treated with these medications. And I think that the implicit discrimination or what's actually happening is much wider spread than what we found in the paper.
And based on what you said, it sounds like some of these facilities were very brazen in their rejections. Do you feel that the referral rejections with no comment were done so intentionally to avoid revealing bias against treating this particular patient population?
Yeah, so we looked at that in the paper. So we looked at whether there was any change in the comments, in the frequency of comments after the U.S. Attorney settlement. So was the kind of what was the additional attention to this issue changing how facilities were reporting their reasons for rejection? And like I said, not all the facilities actually report a specific reason, and we didn't find that changed. So I think this process of referral is very relationship based. Oftentimes the case managers know the specific folks in the facility, and so a lot of these comments were very informal and essentially between colleagues, it sort of felt like. And so I think that there may be some facilities who specifically know that there's guidance that they're not supposed to do this, who are not putting these comments. But I think there's a lot of facilities obviously that are still reporting it in this way.
Yeah, and you mentioned that you have an ally in the U.S. Attorney's Office, and that relationship can be potentially very transformative in the future. However, your study found no statistically significant changes in these discriminatory rejections after the U.S. Attorney's settlement in 2018. So my question is, do you feel that the Americans with Disabilities Act needs to be enforced via some different mechanism in order to achieve better care for patients with substance use disorders?
Yeah, so that's a really good question, and I'd be really interested in hearing, what a lawyer would say. We did find that there was no change in these rejections following this one settlement, but there have since been several other settlements, and actually just this week they announced the U.S. Attorney's Office, in combination with Health and Human Services, announced a settlement with a network of nursing facilities across Massachusetts and Rhode Island. And I think as this was the first settlement that called attention to this, but I think as there's more and more attention to it, then facilities are going to recognize that they really need to develop protocols and really grapple with the need.
Now, what can clinicians do to better advocate for our patients and to help increase our patients' likelihood of being accepted into post-acute care facilities?
So the U.S. Attorney's Office in Massachusetts has trained the U.S. Attorney's offices across the country in how to do these investigations and what these legal cases look like. And so I would, if you have a patient, speaking to clinicians here, if they have a patient who is being rejected from a facility, that I would contact, with the patient's consent, I would contact the U.S. Attorney's Office in your state and ask them to look into it. Now, of course, that's a kind of a longer term way of changing things. It may not actually impact that single patient in front of you, and that's what that's what clinicians are really thinking about on day to day. How do we provide the best care to this specific patient? So it may not solve that problem, and we also need to make sure that facilities feel supported, that facilities feel like there's people, that they have the appropriate training, and that they have the appropriate clinical backup to be able to take care of patients with opioid use disorder well.
Okay, very good, very good. Now, do you have any other information that might be useful to clinicians who find themselves in a situation like this?
The one thing that facilities often say is that there's sort of what they view as low-hanging fruit are people who are stable on medications for opioid use disorder. So, for instance, when I was a resident, I recall taking care of a patient who was on buprenorphine, had been for years, had a extremely complicated hospitalization related to pneumococcal pneumonia, was intubated, and became very weak and needed physical therapy. And that patient wasn't able to access that care. But that patient, their hospitalization, their clinical presentation the opioid use disorder was essentially stable and not really relevant to what was going on with them. And so the nursing facilities, I think, are from talking with them, are more open to taking that kind of patient. The patients who present with immediate complications of for instance, injection drug use, the facilities want to say, well, someone needs to not have used substances for a certain period. And under the Americans with Disabilities Act, they're really still not actually allowed to say that. But that is part of, I think, the facility's concerns, and that they feel like there's not the appropriate support and training there. So I think, as addiction clinicians and educators, we really need to make sure that we're providing linkages and support, and make sure that facilities feel like they have access to our expertise the same way that they have access to a cardiologist's expertise when they're taking care of patients with complicated cardiac conditions.
Very good. Well, I want to thank you again for coming on the show. Dr. Kimmel's article can be found in the January-February issue of the Journal of Addiction Medicine. Thank you all for listening, and thank you so much, Dr. Kimmel, for joining us.
All right, fantastic. Thank you for the opportunity.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.